Okay, so good morning to everyone. Since we are just waiting for our other colleagues to join, let's catch up with something which I would love to share with all of you. My name is Deepthi and I welcome you on behalf of Elsevier family. And this is our proud privilege to introduce you to our panelists. But before I introduce you to all our panelists, there is a thought for the day which I would like to share with all of you, right? So it is actually about self introspection. So this is a very common term which we all know, but what it actually is, you should be reflecting it throughout the day to day. So just reflect back and think about yourself. Do you know yourself properly? Do you actually know your strengths and weaknesses? Do you go back and self introspect yourself, look into yourself and understand what are your flaws, what are your positives, what are your negatives? Do you do that on daily basis before you go back to the bed or when you wake up from your bed? So that is something which will give you strength to end your day successfully and to move on to the next day again very successfully. So as you know, it is said that knowing yourself is a big wisdom. So if you know yourself, you will know others, you will know the you know others also, you will be able to understand others also, and you will try to understand your own environment, your situation, everything. And again, there is nothing outside of yourself that can ever enable you to get better, stronger, richer, quicker, or smarter. Everything is within, everything exists. Seek nothing outside of yourself. So, this is something. What happens is when you are depressed, when you're worried, you try to look out for help here and there, right? That is a time when we need some kind of a support. That's absolutely fine. You reach out to your near and dear ones, you reach out to your loved ones, you reach out to your friends to get some kind of help. But we should never forget that that help will come to you from yourself if you have that faith in you. So I'll just like to project something for the students who are listening to me specifically. Please be very, I think this should give you more encouragement to study well as a nursing professional. So let's look at the next slide. Can you see all these people? Everybody, I'm sure you may be knowing some of them. You may not be knowing some of them, right? So these are the people whom, who are there in our profession and who have excelled like anything in various fields in their own, but their base education is nursing. If you see their credentials, you will understand that they have studied, they have done their education as a nurse, but then they excelled out from their own field and they have created their mark in different professions, right? So that is the strength of nursing that we have, that this education can take you anywhere, right? So just a second. Okay. um right, so these are some of the people whom you should think about, and this is where you have to envision yourself in the near future. And these are some other people who are there in real practices, who were nurses, who had taken up their education as a nurse, but then later on they developed themselves, their own career, and they explored fields of development sector, researcher, corporate sector, health and wellness, as a regional HR, as an educator, as an entrepreneur, as a home healthcare nursing educator, as a chief executive operating officer, and also into airlines, right? So this is the scope of nursing that we have, and none of you as students should be demotivated that you are studying nursing and there is no scope. The sky is the limit. You can reach up to any of these fields, but the most important thing is what you are studying right now. Study it thoroughly, practice it thoroughly, at least have 1 year, 2 years of your clinical experience so that you excel in your own field, and then you can go out and explore other fields. And let me remind you, none of them are working outside India. They are very much in India. All of them are working in India. They are serving their own country. So just keeping this thought in mind, let me introduce to you all the first speaker of the day. And I welcome you all to the third day of this session. Our first speaker for the day is Madam Parul Datta. Madam has retired as a principal nursing officer from West Bengal Nursing Services, about 40 years of experience in neonatal and child health nursing. She is a master trainer of facility-based newborn care, vice president of Indian Association of Neonatal Nurses, and author of the famous pediatric textbook, which I'm sure many of you must be using, recipient of the National Florence Nightingale Award from the President of India in 2008. So she is one of the very known faculty, very known educator among all of us. And today, ma'am will be discussing about the management of hypoglycemia. I welcome you, ma'am.
Thank you. Thank you very much.
I will prompt your slides. Please let me know when you want me to move it.
Okay, thank you very much for nice introduction. Good morning to one and all. Welcome to everybody for today's session as a part of Newborn Week Celebration 2020 by Indian Association of Neonatal Nurses. On behalf of Indian Association of Neonatal Nurses, as Vice President, I again welcome all of you in this today's last day's session. Thanks, organizer, for giving me this opportunity to share my experience regarding the one of the most important problem of neonatal health. So next slide, please. My topic is management of neonatal hypoglycemia. Objective of this presentation is, on completion of this presentation, participant will be able to review their knowledge on neonatal hypoglycemia, identify neonates at risk of hypoglycemia, perform capillary blood glucose estimation by glucometer, and manage neonatal hypoglycemia. Next slide, please. So overview of my presentation is, first I will give some introduction about the topics, then definition and types of neonatal hypoglycemia, along with those neonates are at risk of hypoglycemia, then etiology, clinical features, screening of neonatal hypoglycemia, along with blood glucose estimation procedure. One video will be there. Then management and prognosis and follow-up care of neonatal hypoglycemia, and nursing responsibilities for management of neonatal hypoglycemia with some key messages. Next slide, please. So let us see one case history of a sick neonate. What we usually found in your neonatal units. A term neonate of a primary mother having birth weight 1950 gram brought to the SNCU triage bed on day 3 with the complaint of poor feeding, lethargy, cold to touch, and abnormal movements of the limbs. On examination, the baby is having body temperature 35.8 degrees centigrade, heart rate 170 beats per minute, SpO2 93%, capillary refill time 2 seconds, and capillary blood glucose level is 20 milligram per dl. Let us see what can be the possible diagnosis. So what are the problems? Just previous slide, please. I will just discuss about the case. So baby is having poor feeding, lethargy, cold to touch with temperature 35.8 degrees centigrade. So that means baby is having moderate hypothermia and abnormal movements of limbs with CBG 20 milligram per dl. That indicates the baby is symptomatic hypoglycemia. Baby is hypoglycemia along with seizure. So we have to prevent this condition, we have to identify this condition promptly, and then we have to manage the condition as early as possible, very swiftly. So let us see how it can be done. So next slide, please. So next slide, please. So we know all that in those who are working for the neonates, we know that neonatal hypoglycemia is the most common metabolic problem in the newborn babies. Hypoglycemia, hypothermia, and hypoxia are interrelated problems in neonates. This is related. That means if the baby is hypothermic, baby can have hypoxic and hypoglycemic. So we have to control all these problems. We have to manage and prevent all these problems. Glucose is the vital source for the neonates as nutrient, energy, and required continuously. Glucose is required for normal function of brain and all vital organs. Neonates need glucose either by oral route through milk or by continuous IV fluid or by both routes. One thing we have to keep in mind that asymptomatic hypoglycemia can also cause brain damage. So if it is not managed properly, so we have to identify the asymptomatic hypoglycemia promptly, and management we have to do immediately. Next slide, please. Next slide, please. Okay, so what do we mean by neonatal hypoglycemia? It's the standard definition given by Government of India in the facility-based newborn care. I am not going into other details. There are so many definitions by different authorities. So we are following all over India one standard definition, that is neonatal hypoglycemia is defined as the blood glucose level of less than 45 milligram per dl in all newborns. Next slide, please. So what are the types of neonatal hypoglycemia we found? Already I have mentioned some, that neonatal hypoglycemia we found with some symptoms or without symptoms. That's why it is defined or classified as asymptomatic neonatal hypoglycemia or symptomatic neonatal hypoglycemia. It can be found or diagnosed as resistant or persistent hypoglycemia. Resistant hypoglycemia can also be defined or called as refractory neonatal hypoglycemia, and it is indicated when the requirement of GIR, that is glucose infusion rate, is more than 12 milligram per kg per minute. And persistent hypoglycemia is indicated when with the presence of hypoglycemic state beyond 1 week despite adequate management. So let us see the next slide. So which neonate are at risk of hypoglycemia? We have to identify and we have to think about that neonate and screen about that neonates, and we have to prevent hypoglycemia for these neonates. So preterm low birth weight neonates, especially those weighing less than 2000 gram, infant of diabetic mother, large for gestational age, neonates having intrauterine growth retardation, sick neonates, especially perinatal asphyxia, hypothermia, cold stress, poor feeding, sepsis, shock, respiratory distress, and polycythemia. And those neonates are managed predominantly on intravenous fluid therapy, or those neonates are placed in cold environment and allowed to remain wet. Those baby can have the hypoglycemia. So let's see next slide. So this is a sick baby, and the baby is having hypothermia. That's why under radiant warmer they are placing extra clothing to rewarm the baby. So this baby can have the hypoglycemia. So we have to monitor and screen this condition. Next slide, please. So this type of baby, the small neonate, tiny neonates, and big neonates, if they are cared uncovered, these babies can have the hypoglycemia. Next baby. So this is a big baby. I cannot place, this is my technical difficulties. I cannot place whole size of the baby. This is still now recorded maximum largest weight at birth, that is 7.5 kg, biggest size of baby. This type of big baby, macrosomic baby of the diabetic mother, that baby can also have hypoglycemia. This baby is having 7.5 kg. This is recorded in the that's the highest birth weight. So next slide, please. So let us see what are the etiology of neonatal hypoglycemia. So it can occur when there is limited glycogen stored in preterm and IUGR neonates. It can occur in case of depleted glycogen stored in asphyxia, perinatal stress, starvation. That means if the baby is not allowed to give feeding by the mother or any other person, or baby is having poor feeding or delayed feeding. It can occur in case of increased glucose utilization, in case of hyperthermia. In hyperthermia, there is maximum glucose is utilized due to high body temperature. So that in that condition also neonatal hypoglycemia can occur. In case of polycythemia, that means when the RBC is more in number, then there can have more destruction of RBC, and there can have utilization of energy. So glucose utilization will be there, and there can have due to sepsis and growth hormone deficiency, it can also occur. Another etiology is decreased glycogenolysis. It is very difficult and abnormal pathology, and gluconeogenesis, or in case of use of alternative fuels, in case of inborn error of metabolism, or in case of adrenal deficiency, their hypoglycemia can occur. And also, this is, though it is a very rare condition, but persistent hyperinsulinemic hypoglycemia of infancy can produce to neonatal hypoglycemia. Next slide, please. So what are the symptoms, common symptoms, how the baby present to us with the clinical features? There is no specific or characteristics clinical features of hypoglycemia in neonates. It can mimic any illness like sepsis, hypothermia, etc. So common symptoms we usually found, this is a bundles of features. That is poor feeding, lethargy, limpness, weak cry, not looking well, irritability, even high-pitched cry, tachycardia, hypothermia, cyanosis, dusky color, poor respiratory effort, apnea or tachypnea, hypotonia, excessive sweating. This is very rare in newborn, but in hypoglycemia it can happen. Then excessive jitteriness, tremor-like movements, tremors, seizures. It is the symptomatic hypoglycemia is usually present with seizure, and baby can have coma. Next slide, please. So there is a standard guideline for recommended guideline for screening time of at-risk neonates for hypoglycemia. So if we are not doing the screening, so then baby can have hypoglycemia and neurological deficit. So purpose of screening and monitoring is to anticipate hypoglycemia and to prevent symptomatic hypoglycemia in at-risk neonates. Screening should be done at 2 hours of age, then 6 hours, 12 hours, 24 hours, and 48 hours of age. And even if indicated, it can be done at 72 hours of age. Screening is usually done by capillary blood glucose estimation, that is by CBG estimation. Next slide, please. So please video. So we'll see, I have taken this video from WHO Collaborating Center AIMS. I'm thankful to them. This is a very excellent video. So that's why I like to share this video. Who have done, I will not be able to name all persons who have prepared this, but it is an excellent video. I think it is now nobody can do better than this. Okay, video please.
Please give me a second to project the video.
Okay, thank you.
Yeah, so that you can hear it with the sound.
Okay.
This video will show you the heel prick for glucose estimation. Glucose monitoring is indicated in growth retarded low birth weight infants, infants of diabetic mothers, and in sick neonates. For glucose monitoring by heel prick, we need spirit swabs, 26 gauge needle, glucometer and reagent test strips, and a bowl filled with lukewarm water. Warm the heel by putting in warm water at a temperature of 42 to 43 degrees centigrade or using steamed towels. Wear gloves and identify the site of heel prick. Remember, the heel prick should be done only at the side of the heel and not at the middle portion. Clean the identified site with spirit swab. Allow the spirit to dry. Then puncture the site with a 26 gauge needle and wait till a drop of blood is formed. Let the blood drop fall on the strip. Insert the strip into the glucometer and wait till the result is displayed. Document the value in the patient's record. Some do's and don'ts. Clean the site with only spirit swab. Do not use iodine swabs for cleaning the skin. This will elevate the blood sugar result. Do not prick the middle portion of the heel. Do not squeeze for obtaining the blood drop. Do not rub the strip against the skin while collecting the drop. Thank you.
Okay.
Can go to the next slide.
Next slide, please.
Yeah. Please
Next
let
slide,
me know
please.
when you can see it.
Okay. Okay. Thank you. It's there. So thanks to whole team of AIMS Neonatology department to give us this excellent video. We used to, whenever we do any training program, we used to this video. So I thought I will not be able to do better than this. So that's why I have used. Thanks to everybody who have prepared. The names are there, and voice, that person who have given the voice, I know him also. So it's a very excellent video. But some, again, I like to re-emphasize that precautions during CBG estimation by heel prick using glucometer. One point we used to in our place, and as a teacher, I always like to emphasize that before heel prick, as it is a very painful procedure, so we can do CBG estimation by venous blood. But before heel prick, usually commonly we are doing with the heel prick. So as it is a very painful procedure, what we have to do, we have to follow the precautions for pain reduction. I forget to write that points. That's why I am explaining. So we have to take the measures especially by the non-pharmacological measures to reduce the pain due to heel prick for the neonates. So what we can do, we can give 2 to 3 drops of breast milk in the baby's mouth 2 to 3 minutes ago. Then baby will have feelings of security, and baby will take the taste of that, and baby will have less pain. Another thing we can do, that we can hold the baby and we can support the baby with swaddling or wrapping or with the hand holding or hand containment. So that can help the baby to feel the reduced pain. So pain management is another important point. There is some recommendation of sucrose, sucrose or any other things, but I am not giving because sucrose is not available in our country sometimes. Some places it is available, but as a nursing personnel, we can give 2 drops of breast milk to the baby's mouth, and that will be very helpful for the pain reduction. Other precautions is meticulous hand hygiene we have to maintain, because repeated heel prick can produce the sepsis of that particular area. So hygienic and aseptic precautions we have to maintain. Expiry date of the glucometer reagent strip we have to check. We have to already it has shown and told that ensure heel is warm. If it is cold, then we have to rewarm. Then we have to rewarm the heel. Even we can rewarm the heel by holding the baby's heel by our hands only when our hands are warm. Then prepare the skin of heel prick area using only 70% alcohol swab in circular motion. And then allow drying of that area before prick. Don't use povidone iodine. Perform heel stick at posterolateral aspect of heel. Avoid prick at central portion to prevent the calcaneal injury. And then use sterile lancet. Some places the nurses are using sterile lancet or needles. 26 gauge needle can be used. Usually what we are doing, it is recommended that first drop of blood we can discard, because then first drop of blood can have the fallacious result. So second drop of blood we can take in the test strip of the glucometer. Thank you. Next slide. Next slide. So let us now discuss about the management of hypoglycemia. I have divided into asymptomatic hypoglycemia and symptomatic hypoglycemia. Always it is recommended by the standard guideline that whenever we receive a baby with neonatal hypoglycemia having the blood glucose estimation, depending on that, we will divide the baby into 2 groups, that is asymptomatic and symptomatic. Then we will start management. If the baby is asymptomatic, first our responsibility is to maintain warmth for normothermia. So we have to place the baby under radiant warmer. Then we have to monitor heart rate, SpO2. So we have to attach the pulse oximeter. We have to monitor body temperature. So we have to place the baby in servo mode. Then we have to send the blood sample for plasma glucose to the laboratory. Then if the blood glucose is more than 25 but less than 45, that means if it is between 26 to 44 milligram per DL, then at first we will give, that is asymptomatic, and if the baby is having no symptoms, then we will give breastfeeding if the baby can able to take the breastfeeding from the mother and mother is available. Otherwise, we will give the express breast milk or top feeding 20 to 30 ml. Then we will check the blood glucose by CBG after 1 hour of feeding. And then after 1 hour, we find the blood glucose is 45 milligram or DL or more. Then we will encourage the mother to give frequent breastfeeding, and we will monitor the blood glucose every 6 hourly. There is a flow chart by the recommended by the Government of India. I have not used that flow chart. I have written in this way, so you can refer that also. If the blood glucose is less than 45, even after 1 hour of feeding, then we have to start the blood glucose, dextrose infusion with the GIR 6 milligram per kg per minute. Next slide, please. But if we found that asymptomatic baby with the capillary blood glucose is less than 25 milligram per DL, even after 1 hour of feeding, then we have to treat that condition as a symptomatic hypoglycemia, and we have to manage as a symptomatic hypoglycemia. And even if the baby after 1 hour of feeding, if it is then, and in the first point, if it is asymptomatic, and from the very beginning, if the baby is 25 milligram or per DL or less, then also we have to treat it as symptomatic hypoglycemia. So asymptomatic baby, two situations can be treated as symptomatic hypoglycemia. I am repeating. First, if the neonate is asymptomatic, but CBG is at first only less than 25 or less, then we will treat as symptomatic. And if after 1 hour of feeding, it is 25 or less, then we will treat as symptomatic hypoglycemia. So next slide, please. So to treat the symptomatic hypoglycemia, so again we have to maintain warmth for normothermia under radiant warmer. We have to monitor heart rate, SpO2, body temperature, and plasma glucose. And then we have to establish IV line. And with that IV line, we can send also the venous blood glucose. We can check again venous blood glucose. And then we have to administer 10% dextrose bolus, 2 ml per kg of body weight slowly over 1 minute. Time is very important. We will not give longer time. So it should be given the calculated amount in 1 minute. Then we have to start the glucose infusion with the GIR 6 milligram per kg per minute. Next slide, please. If there is any problem or we cannot establish IV line, because sometimes baby is so sick that IV line cannot be established quickly, then we can give OG tube feeding with the same calculated amount, and then we will establish gradually. We will go for the then when the baby will be little stable, then we will go for the IV line and we will do the management, further management. So after that, we have to blood glucose checking we have to done after 30 minutes. This is the difference. In asymptomatic, we have done after 1 hour, but in symptomatic, we have to check the CBG after 30 minutes. And then after 30 minutes, if we find that 45 milligram per DL or more, that means baby is normoglycemic, then we will start oral feeding and monitor blood glucose every 6 hourly, as previously I have told. But if till after 30 minutes baby is hypoglycemic, that means less than 45 milligram per DL, then we have to increase the GIR 2 milligram per kg per minute or as needed, gradually and slowly. And then again we have to check the blood glucose after 30 minutes and we have to decide for the further management. This is standard protocol in emergency. Nursing staff also can do with telephonic or consultation with the, if the doctors are busy, they can start with that. Next slide, please. So to continue with others, if the blood, other points and other findings, if the blood glucose remains 45 or more for 24 hours, then already we have given the 10 milligram per kg GIR with 10 milligram per kg per minute. Then if the blood glucose remains more normoglycemic, that means 45 milligram per DL for more than 24 hours, then we have to gradually reduce the blood glucose every 6 hours. And then we can start oral feeding, and when there will be oral feeding, we can monitor glucose depending upon the level or after 6 hours. If GIR requires more than 12 milligram per kg per minute, then it indicates the refractory hypoglycemia. And then the baby requires injection hydrocortisone 2.5 milligram per kg stat IV and needs special evaluation for the further management to find out the underlying pathology, why this baby cannot be managed even after giving GIR more than 12 up to 12 milligram per kg per minute. One thing we have to keep in mind that maximum strength of dextrose we can give in the neonates in the peripheral vein is 12.5%. Never use 25% glucose in the peripheral vein. If the baby needs more than 12.5% dextrose, then we have to establish the central vena. We have to do central venous catheterization, PICC line. Then only we can give the more than 12.5% dextrose through central venous catheterization. Next slide, please. So there is some formula for calculation of glucose GIR rate calculation. It's the GIR equal to dash ml per kg per day into dash percentage of dextrose into 0.007 equal to, we will get the GIR. For example, in the day 1, less than 1500 gram baby, usually they get the 80 ml fluid per kg. So 80 ml per kg for that day into, and on that day, day 1, they are getting 10% dextrose. So 80 into 10 into 0.007 equal to 5.6 milligram per kg per minute. So that's the approximately 6 milligram initial we are starting with this GIR. And there is also available GIR calculation table for the neonates having birth weight, day of life, and recommended fluid volume. With that recommended that chart, standard chart, we can cross check the GIR calculation. Even GIR calculation can be checked by the doctors and nurses, or two healthcare provider or two healthcare professionals can check the GIR calculation. Because if we are giving more GIR, then baby can have hyperglycemia that can produce more problem for the management. Next slide, please. So how the frequency of blood glucose estimation after blood glucose return to normal. If the baby is receiving IV fluid for any reason, continue blood glucose measurement every 6 to 8 hours. Usually 8 hourly people are doing. Some setup they are doing 6 hourly, as long as the baby requires IV fluid. If the baby is no longer required or not in receiving IV fluid, measure blood glucose for 12 hours, for 24 hours. That means 2 times. If it is normal, then discontinue blood glucose estimation. But if it is again less than 45 milligram per DL, then treat as the hypoglycemia. Already I have discussed previously. Thank you. Next slide. So prognosis and follow-up in neonatal hypoglycemia. So we know that hypoglycemia in neonates can produce brain injury and long-term neurodevelopmental problems such as seizure, developmental delay, visual problems, and cognitive deficit. They will have low IQ. So neonatal hypoglycemia must be followed up for neurodevelopmental status at frequent interval, and developmental supportive care as early stimulation and early intervention should be provided from the SNCU or NICU as early as possible. And then follow-up care and assessment at 1 month of corrected age should be done for vision evaluation, because this baby has visual problem, and at 3, 6, 9, and 12 and 18 months of corrected age, the evaluation should be done for growth, how the baby is gaining weight, and then for neurodevelopmental outcome and vision and hearing loss. The baby can have these problems in future. So we have to assess the baby in follow-up care. Next slide. So what is our responsibility as a nursing staff? We all know this is with that basis of the theoretical knowledge, we have to do the assessment and problem identification by history of illness, observation and examination of the neonate for clinical features and blood glucose estimation. Then we have to plan for nursing intervention based on priority problem, that is providing warmth under radiant warmer, monitoring by pulse oximetry, and we have to provide oxygen therapy if required and maintain the oxygen saturation 90 to 94%. We have to do IV line, and we have to give 10% dextrose bolus for the symptomatic neonates, and dextrose infusion we have to give. Otherwise, we have to give feeding, and then monitoring of CBG, recording and reporting, communication to the team member and the family members, and follow-up care in long-term neurodevelopmental outcome. And implementation should be done of the new nursing intervention as per plan and as per priority problem. And then evaluation of nursing intervention for further management should be done and for follow-up care of the neonates. And then we have to do the further management. Next. So what is the key message of my presentation? We have to keep in mind, though we are if we ignore the feeding, then there will be problems of the neonatal hypoglycemia. It's a problem of preterm low birth weight sick neonate, and in case of infant of diabetic mother and IUGR, and so many cases can have this problem. Early initiation of breastfeeding within 1 hour of birth. This is mostly all nursing responsibility, and frequent breastfeeding helps to prevent neonatal hypoglycemia. It is our responsibility. Mother needs breastfeeding counseling and support to prevent neonatal hypoglycemia, especially those are the primary mother and those having the small tiny babies. So especially physical support is very, very important to promote the breastfeeding. Then this problem can be prevented. And if it is not able, we cannot able to prevent, then early identification of the neonatal problem and prompt initiation of management of this condition will help to promote better neurodevelopmental outcome of the neonate or infant for their intact survival. We don't have right to do any harm, so we have to prevent this condition. So we have to keep in mind that we have to help the infant for their intact survival without doing no harm principles, and we have to do the quality improvement of our activities. Thank you, everybody. So next slide. So thank you. So next slide, last slide. Thank you, everybody, for patience listening. I think I have tried to give all the informations. If you need, you can read from the website or facility-based newborn care guideline, or there are so many guidelines are available. Okay, any questions you can place in the chat box.
Thank you so much, Madam Parul. I think just perfect timing. And, I myself went back to my own classes of pediatrics. So thank you so much for such a detailed and informative session. You may have some questions in the Q&A tab. Kindly go there and answer the questions how much as possible in the chat. And we will get back to you for other questions. Thank you so much for your session.
Thank you. I'm leaving. I will be in around 1:30. Okay. Okay,
sure,
thank you.
sure.
Thank you. Thank you.
So let me introduce you to our next speaker of the day.
Hello.
Okay, so we have Madam, or I must say Dr. Alpanamai Bera. Madam is a professor, Government College of Nursing at Bankura Sammilani Medical College, West Bengal. Madam has a master's degree in pediatric nursing from RK College of Nursing, PhD in the field of neonatology from West Bengal University of Health Sciences, presented papers and delivered speech in various national and international conferences, published paper in national and international journals, as well as she is providing services and attached with the newborn care since 2005. So it's a long time that she has been in the service of newborn care and still serving very, very, actively in the team. Today, ma'am will be discussing about the management of shock, and I welcome you, ma'am, to this session. I'll just give me a moment to prompt your slides and let me know if you can see it.
Hello.
Yeah, can you see your slides?
Thank you. Yes. Yes.
Okay.
It's okay. Thank you, Deepti. I first convey my gratitude to the organizing committee to give me the opportunity. Now we discuss on neonatal shock. Next slide. Slide, please. Next slide, please. Objective of shock is hello. Objective of shock are identify shock, enumerate the different causes of shock, perform fluid resuscitation, use vasopressor and perform nursing response. Next slide. Next slide, please.
Yeah, ma'am, I'd like to mention that I think your internet connection is a little slow, so you might see the slide a minute later. Okay.
A sick neonate may present with shock or it appears during the course of disease. The success of management depends on prompt diagnosis and appropriate management. Next. Shock is a, next slide. Shock is a clinical state of poor function of body tissue in which the baby's demand of oxygen nutrient. This can result in tissue hypoxia and metabolic acidosis, causing irreversible tissue damage. Shock and hypotension are not synonym. Hypotension is a late sign of shock. Next slide. Next slide. How to identify unexplained tachycardia, that is the heart rate more than 60 per minute, and checking the capillary refill time. CRT is the rate at which the capillaries refill following empty by pressure, indicates adequacy of tissue perfusion. Next slide. And how to check refill time, that video I will show later on. First, the CRT checked on the central part of the body such as chest. Gentle pressure is applied by the thumb for 3 to 5 seconds. By counting from 1 to 5, this results in blank on the underlying surface. Next slide. Observe how fast the blanch area refills and become pink after the thumb is lifted from the skin surface. Normal capillary refill time is less than 3 seconds. A prolonged capillary refill time that is more than 3 seconds indicates poor tissue perfusion. Next slide. Next slide. Shock may be grouped as hypovolemic shock, blood loss due to feto-maternal or twin-to-twin transfusion, birth trauma, disseminated intravascular coagulation, and pulmonary hemorrhage. Next slide. Fluid loss due to excessive insensible water loss, poor perfusion, poor fluid intake, vomiting, diarrhea, polyuria, and cardiogenic due to low cardiac output, asphyxia, patent ductus arteriosus, and other congenital heart disease, arrhythmias, hypoglycemia, and acidosis. Obstructive shock. Next slide. Next slide, please. Obstructive shock, that is aortic stenosis, quartet and pneumothorax, and distributive shock due to anaphylaxis, neurologic, and septic shock has multiple etiology, that is hypovolemia, distributive due to decreased afterload, and cardiogenic due to muscle depression and endotoxins. Next slide. Next slide. What are the clinical shock? There may be poor peripheral pulses, pallor, skin, cold extremities, decreased urinary output, low blood pressure. That is, this blood pressure is the late sign of shock. Next slide, please. Next slide. Now come to the management. The outcome of shock depends on early diagnosis and prompt management. The supportive management may maintain temperature, airway, breathing, and circulation. Hypoxia, that is give oxygen to maintain hypoxia, give high oxygen to maintain normoxia, that is should be on 90 to 94%, and treat hypoglycemia, maintain normal blood glucose level more than 45, and hypothermia, maintain temperature that is 36.5 to 37.5 degrees. Next slide. Next slide, please. and specific management. Restoring of perfusion is the cornerstone in shock fluid resuscitation. Infuse fluid bolus of 10 ml of normal saline over 20 to 30 minutes. For example, baby weighing 3 kg, 30 ml of normal saline to infuse 20 to 30 minutes. Next slide. Next slide. Assess for improvement, 30 decrease in heart rate by at least 10 beats per minute, and if no partial improvement, a repeat bolus of normal saline will be given. After 2 fluid bolus, if no signs, if signs of poor perfusion persist, start vasopressor, and along with vasopressor support, supportive care. Next slide. Next slide, please. Assess for improvement by next slide. Most commonly used in neonatal practice, dopamine. Dopamine is used as the first line agent. Effects on preload, myocardial contractility, and afterload. Usual starting dose of dopamine is 5 to 10 microgram per. If no improvement, dose can be increased by int of 5 microgram per kg per minute every 30 minutes to maximum of 20 microgram per kg per minute. Next slide, please. Now we have to see how to calculate the dopamine. This is one of the important responsibilities. We have to use insulin syringe for loading dopamine. Dopamine injection contains 40 milligram of dopamine, baby weighing 2.5 kg, and if we want to start dopamine at a rate of 10 microgram per kg per minute, we have that is 10 into 2.5 equal to 25 microgram per minute. Again, if we convert in hour, that is by 60, that comes to 1500 microgram hour. And again, if you convert it into 24 hours, that is by 24, it comes to 36,000 day, which is equivalent to 36 milligram, that is 0.9 of dopamine in 24 hours. And if we in 8 hourly, that is it comes to 12 milligram, that is 0.3 ml dopamine in 8 hours. Next slide, please. Next slide, please. It means if we add 0.9 ml of dopamine hours of fluid and give at a rate of 1 ml per hour, we will give dopamine at the desired rate, that is at the rate of 10 microgram per kg per minute. So after 30 minutes of starting dopamine drip, to monitor the neonate status of perfusion by assessing CRT and pulse volume. If there is inappropriate response, increase the dopamine by 5 microgram per kg per minute by increasing the rate of infusion to 15 ml per hour to provide microgram per kg per minute. Next slide, please. With improvement in perfusion, decrease the infusion decrement of 5 microgram per kg per minute. As long as the infant is on dopamine drip, the status of suppression needs to be monitored. Despite of dopamine 20 gram per kg per minute, that is the highest dose, the neonate is continues to be in shock. Dobutamine is second choice of vasopressor. It is used in combination with to improve the out is same as dopamine. Next slide. Next slide, please. Next slide. Cortisone is considered in neonate who maximal dose of both dopamine and dopamine per kg per minute. The initial dose of hydrocortisone 1 milligram per kg, then depending on the age of the baby. It can be given 8 to 12 hourly in a dose of milligram per kg for 2 to 3 days. And assess neonates to be done every 6 to 8 hours. Next slide. Next slide, please. Unresponsive shock may not respond to the above treatment in sense of hypoglycemia, hypoxia, hypothermia, hyperkalemia, anemia, and pneumothorax. If required, consider and if hemoglobin level less than 12 g/cent. And the referral after stabilization of the temperature, oxygen, and glucose. Next slide. Next slide. Then therapeutic endpoint. Treatment should be modified as per assessment and achieve our required, that is capillary refill time less than 3 seconds, normal heart rate, normal pulse, and warm blood pressure normal, and urine output 1 ml per kg per hour. Next slide. Next slide.
Yes, ma'am.
Weaning from ionotopes. When we do weaning, once hydration improves, that is normal blood pressure for 4 to 6 hours, and improves. So how we wean ionotopes? That is taper slowly at the rate 5 microgram per kg every 1 to 2 hours, and provided the neonates continue to maintain the therapeutic endpoint. Next slide. Next slide. Then referral. When to refer? If the neonate has unresponsive, refer urgently. If refer is not possible, consider use of adjustable and continue supportive care. Next slide. Key messages are: monitor all sick babies for sign of shock. Start treatment immediately if shock. Supportive care, fluid resuscitation, and ionotopes monitoring are the prime nursing responsibilities. Administration of fluid and ionotopes are continuous prime responsibilities of the prime nursing responsibility. Next slide. In conclusion, sincere, competent, and quality nursing care can make the differences in survival of newborn. Thank you. Now show the. Hello.
Okay, just give me a second.
Please
just give
share
me
the video. This is
yeah.
the capillary refill time.
Sure. Just give me a moment. Please give me a moment to put on the video. Okay. Please let me know if you can hear it, madam. Okay. Yeah.
Video I am not hearing.
Okay. We'll hear it now.
Many residents and doctors do not know the correct method of eliciting capillary refill, also called as the capillary filling time. This video shall demonstrate the same. It is the time taken for filling of the capillaries once they have been emptied by blanching. It suggests whether or not the perfusion is adequate. Basically, it denotes perfusion of the superficial capillaries. Normal value is less than 2 seconds, but earlier this cutoff was taken to be 3 seconds. It is a very integral component of evaluation of a newborn. To elicit it, first select a site which is rich in capillaries. It is sternum in newborns because the skin in newborns is too thin and the capillaries are easily visible through the skin in them. Also, the pulp of finger in older children can be used to elicit CRT. Now apply superficial touch for 5 seconds. Remove your fingers and count the time in which the blanched area recolorizes, that is, refills again. Now the issue is that most of the people just guess the time as 5 seconds for blanching and 3 seconds for recoloring, and this leads to fallacious interpretations. So, how do you count the seconds? Count like 1001, 1002, 1003, 1004, 1005. That is 5 seconds for blanch. 1006, 1007, 1008. That is 3 seconds for refill.
1001, 1002, 1003, 1004, 1005, 1006, 1007, 1008.
This is the video of a 28-week premature on ventilator. Remember, the count between the blanch and the refill, that is between 1005 and 1006, should be done in continuation, and here is that most of the people falter. Now have a look in another video.
1001, 1002, 1003, 1004, 1005, 1006, 1007, 1008.
See, the refill has occurred before we could count and finish saying 1007. That is in less than 2 seconds. So this is the normal capillary refill. Now delayed capillary refill can be seen in conditions like severe dehydration or shock, hypothermia, metabolic acidosis, severe sepsis, and peripheral vascular disease, which is uncommon in children. Also remember that capillary refill is brisk in warm shock while it is delayed in cold shock. This happens because the pulse pressure is wide in warm shock while it is narrow in cold shock. Thank you, and do share the knowledge.
So, thank you, ma'am. I think we are done with your session, and thank you so much for your perfect timing again.
Thank you.
So let me introduce you to our next speaker. So this session will be a combined session, and it will be taken by two very vibrant nursing officers. I'm very happy to see that we have a mix of educators as well as the nursing officers together, because where a platform we share our clinical as well as our practical knowledge. So we have Madam Jeena Pradeep. She's an RNRM and working as a senior nursing officer at Kalavati Saran Children's Hospital, New Delhi. She is a PhD scholar at Amity University, governing body member of NQOCN, national mentor for Lakshya program, external assessor for NQAS, and resource person for QI. Also, the National Florence Nightingale Award winner of the year 2016. I welcome you, Madam Jeena.
Thank you. Thank you.
The second speaker is Madam Sri Nitya Raghavan. She is working as a senior nursing officer in service educator at AIMS, New Delhi. Madam has her master's done from Jamia Hamdard and a BSc from AIMS, New Delhi. With 26 years of professional experience, she is an active member of ISN. I again welcome you, ma'am, Srinitya, and both of them will be taking the session on management of neonatal seizures. Over to you, Madam Srinitya.
Can I share my screen on my own? Yeah.
Yes, yes, please.
Thank you.
I will just request the participant to put in their questions in the Q&A tab. And if there is any query you have regarding the sessions which have already been over, please type in your questions there and it will be answered. If there is anything which is left, we will answer it at the end.
Can you see my screen now?
Not yet. It's, I think, just popping up. Have you shared the screen?
Yeah, yes.
Okay, it may be just taking a moment. It's not yet visible. I think you haven't clicked that share screen icon at your screen. Yeah, now it's there.
Yes, it's coming now.
Now it is visible.
Great. Yeah, please go ahead. Yeah.
Skip the
Yeah. Very good morning to all, and thanks to organizer for giving this opportunity. And today's topic is on management of neonatal seizures. The main objective of today's class is that to identify the neonatal seizures and enumerate causes of neonatal seizures, and to elaborate nursing management and the pharmacological management of the neonatal seizures. Just to give the introduction to this topic, as we all know, the neonatal seizures are the most frequent and distinctive clinical manifestation of the neurological dysfunction in the newborn infant. And infants with neonatal seizures are at risk of neonatal death or neurological impairment disorders in later life. And the neonatal seizures are usually the clinical manifestation of the serious underlying disorders, and it is a signal because they signal a disease process that may produce irreversible brain damages. Though the mortality due to neonatal seizures has decreased over the period from 40% to 20%, but the prevalence of the long-term neurodevelopmental sequel has largely remained unchanged at around 30%. That is the main reason that the improper and inadequate management of the seizures could be the reason behind this neurological problem for the children. Just to define neonatal seizures, the seizure is defined clinically as a paroxysmal alteration in neurological function, that is motor, behavior, and autonomic functions. The definition can be divided as epileptic seizures, that is a phenomena which is associated with the corresponding EEG changes, and the non-epileptic seizures, that is the clinical seizures without the corresponding EEG changes, that is subtle or generalized tonic seizures, and the EEG seizures, that is abnormal EEG activity with no clinical correlations in that one. The classification of the seizures can be as a subtle seizures, tonic seizures, tonic-clonic, and myoclonic seizures. What is subtle seizures? It is especially seen in the preterm and also in the term babies. It is the clinical manifestations are very mild, or sometimes we frequently miss out all these seizures. It is not, it's very difficult to diagnose. Sometimes it is very mild, and it usually mild paroxysmal alteration in motor behavior or the autonomic function, and it is not clearly the clonic, tonic, or myoclonic. And the commonest type is this very common type seen in the newborns. It constitutes 50% of the all seizures. Next is a tonic seizures. It is just I wanted to say that in subtle seizures, what we can see is that babies may be the sustained eye opening with ocular fixation will be there. Sometimes the baby will be seeing in the eye is fixed to one point, or there will be the very mild movement of the tongue thirsting or the lip smacking, etc. These things we commonly miss out, that the seizure is happening with these babies. And the tonic seizures, or the primarily it happens with the preterm babies, and it is characterized by flexion or extension of the axial or appendicular muscle groups. It may be focal or it may be generalized. That is decerebrate, that is the tonic extension of all the limbs, or decorticate, that is flexion of the upper limbs and the extension of the lower limbs. And mainly in tonic seizure, what we see is there won't be any ECG changes that happens with the baby. Next is the clonic seizures. They are rhythmic movements of the muscle groups. It is mainly seen in the primarily in the term babies, and they have both both fast and the slow components. Like 1 to 3 jerks per second happens in the seizures happens in the babies, and it is always associated with the EEG changes. And the last type is the myoclonic seizures. The myoclonic are the single or the multiple lightning fast jerks of the upper or the lower limbs. It usually distinguished from the clonic movement because of more rapid, and it is myoclonic seizures carry the worst prognosis in terms of neurodevelopmental outcome, and the focal clonic seizures have the best prognosis, whereas myoclonic seizures has a very poor prognosis. It leads to lots of neurological problem with the newborns. The main the causes for the seizures that may be hypoxic ischemia, ischemic encephalopathy, which is secondary to the perinatal asphyxia. That is the most commonest cause what we see in the, for the babies with seizures. And the some birth injuries, meningitis, metabolic conditions, and hypoglycemia, as ma'am has already explained, that is also one of the reason for seizures. Hypocalcemia or the hyponatremia. These are the metabolic causes, or the intracranial hemorrhage, and some developmental defects also leads to the developmental defects like cerebral dysgenesis and neuronal migration disorders are the common causes for the seizures in the newborn periods. And the spasm and the seizures, how can we differentiate? Is that spasm is the involuntary contraction of the muscles. The fists often persistently and tightly clenched, and trismus epistotonus triggered by the touch, light, or by sound, and baby is conscious throughout, often crying with the pain. And approach to an infant with neonatal seizures is as a nurse, the history taking is very, very important when we approach the seizures in these babies. Mainly the seizure history is very important. A complete description of the seizure should be obtained from the parents or by the attendant or whoever is looking after the baby. There should be the history should be associated with the eye movements, how the eye movement was, whether the restraint of episode by passive flexion of the affected limb, or there is any change in the color of the baby like mottling or any cyanosis or any autonomic phenomena, etc. And the antenatal history is also very important because these history is suggestive of the any intrauterine infection or any maternal diabetes or any narcotic addiction. It should be elicited. And the perinatal history is very important. That is, that's why I told one of the causes that perinatal asphyxia. And the feeding history, how the baby was feeding, whether the baby was lethargic, whether it was a poor activity, drowsiness is there, any vomiting is there, all these history. And the family history is also very, very important in these when we take the history taking for the babies with the neonatal seizures. And in the examinations, as we all know, the vital signs are very important. The heart rate, respiration, blood pressure, capillary refilling time, and the temperature should be recorded in all the infants. And the general examination, overall head to toe examination has to be done on these babies, and the CNS examination and the systemic examination for hepatosplenomegaly is there, or any other abnormal urine order or anything has to be obtained. And the mainly investigations, like essential investigations, all the blood tests, if we need rule out meningitis or anything, CSF can be CSF fluid can be sent for examination, ultrasound if needed, cranial ultrasound or EEG. These are some of the essential investigations. Some of the other additional investigations like the MRI, CT scan, or if any maternal infection is there, torch or something like that can be done on these babies to rule out the nature of why the baby is getting seizures and what may be the underlying phenomena on this. Then we move on to the nursing management. The initial management, everybody knows, for all the sick babies, so ensuring the thermoneutral environment is very important, and always keep the resuscitation trolley ready, because anytime the baby may need it, and ensure a patent airway, effective breathing, and adequate circulation, and start oxygen therapy. And IV access is very important in order to do the pharmacological management, and blood samples should be taken for serum calcium and for the blood sugar, which is which are the major causes for seizures in newborns. And first management is we have to correct the hypoglycemia, as we had a detailed session on hypoglycemia. If the blood glucose is less than 45 mg, the main management is 10% dextrose bolus has to be given 4 to 5 ml per kg, and it should be followed by the maintenance of 6 to 8 mg per kg per minute. And next thing is you have to correct the hypocalcemia. That is 2 ml per kg of 10% calcium gluconate IV over 10 minutes. And always remember, whenever we are giving calcium gluconate, it should be given under the cardiac monitoring. If any heart rate is increasing more than 100, you have to stop infusion. And it is better that using the infusion pump is a better way of administering calcium. And hypocalcemia, if persist, the calcium gluconate at 8 ml per kg can be per minute can be given in this patient. And the anticonvulsant drugs, mainly the drug of choice is the phenobarbital, is the drug of choice. And initial dose is 20 mg per kg IV slowly over 20 minutes. And repeat the dose if the seizure persists. Phenobarbital at the rate of 10 mg per kg every 20 to 30 minutes. And also remember that 40 mg per kg is the highest limit for phenobarbital. And then once the loading dose, the seizures is controlled with the loading dose, then maintenance dose at the rate of 3 to 4 mg per kg per day in 1 to 2 divided doses. And be careful and watch for any potential respiratory depression with the higher dose of phenobarbital. And the next drug of choice is the phenytoin. It is indicated if the maximal dose of the phenobarbital, that is 40 mg per kg, fails to resolve the seizures or earlier. The dosage is 20 mg per kg over 20 to 30 minutes, and repeat the dose of 10 mg per kg per day in 2 divided doses. And the maintenance dose later on is 5 to 8 mg per kg per day in 2 divided doses. And the main caution with the phenytoin is that it should be mixed with the saline, not with 5% dextrose, as it precipitates with the dextrose. And the oral administration has very erratic absorption, so it should be avoided. Only IV route is preferred, and it should be discontinued before discharging the child. We should not discharge a baby on phenytoin. As calcium gluconate, already I have discussed about this. And next drug of choices, very rarely we may go for benzodiazepines in the drug of choice for these babies. The commonly used benzodiazepines are lorazepam and midazolam. And We never use diazepam, as generally it is avoided in neonates because of its short duration of antileptic effect, but very prolonged sedative effect is there. So nowadays, what the drug of choice is only midazolam or lorazepam. Midazolam is faster acting than the lorazepam and may be administered as a, can be administered, but it's a respiratory depression and sedation is less than the lorazepam. The dosages for lorazepam 0.05 mg per kg IV bolus over 2 to 5 minutes. It may be repeated. For midazolam, it is 0.15 mg per kg IV bolus followed by the infusion. When to discontinue all the medication at the time of discharge if the neurological examination is okay, and there is no need to taper the anti-convulsive drugs in these babies. And do not use diazepam or midazolam for control of convulsions in neonates. Continue supportive care and treat the underlying causes like meningitis. And what we have seen is that mostly 40% of the seizures in the newborn are treated with the phenobarbital itself, and only 70% to a total of maybe we may have to exceed to 40 mg per kg of phenobarbital, and 85% of the seizures in newborns are controlled by phenytoin. Very rarely we may have to go for lorazepam or midazolam on these babies. It is a flowchart just to show that just to summarize the topic. We have to identify and characterize the seizures. Next, to secure the airway, start the oxygen immediately, and secure IV access, and take the samples for blood sugar, hematocrit, calcium, magnesium, and all the other electrolytes. And if blood sugar is less than 45, start with the 10% dextrose. And if the calcium is low, you have to start with the calcium. And if still the seizures continues, then we have to go for phenobarbital and or then to phenytoin, and then to the maintenance doses. And always remember that before discharging the patient, it should be discontinued, or if the seizures are uncontrolled. If we are managing the seizures in the primary care center, then we can refer it, or further management is necessary to identify what is the reason for the seizures. So this is the summary. Seizure in the newborn period constitute a medical emergency. The septal seizures are the most commonest type of seizures occurring in the period. Other types include tonic-clonic and myoclonic seizures, and myoclonic seizures carry the worst prognosis, and hypoxic ischemic encephalopathy is the most common cause of neonatal seizures. And other like hypoglycemia, hypocalcemia, meningitis. So these need the specific therapy. So thank you very much. If you have any doubts, we can clear it. Or if the time permits, can I show one video for identifying myoclonic seizures and clonic seizures?
Yes, yes, you do have the time. You can.
Yeah.
Please go ahead. Yeah.
Thank you. Is it visible, my screen?
No, not yet. You have to share it again.
Okay.
Please select the computer audio sound once you start sharing the screen so that the voice is audible.
Yes,
Now,
yes.
it is, yeah.
Yes, yes.
You can enlarge it, maybe.
So this is myoclonic seizures. It's a continuous, so whereas the clonic seizures, you can see only 1 or 3 jerks in a minute. Whereas in this seizures, you can see continuously the child is having the seizures. I have one more.
Is there any other video?
Yeah, one more video.
Okay.
This is the focal clonic seizures, where the seizure movement is very less, whereas in the previous video we saw that it is a fast jerking movement. This is a clonic seizures. Yeah. Thank you.
Thank you so much, ma'am. I think that was a wonderful session, and I believe we have utilized to the maximum this online platform to reach out to our students and faculty. Generally, I'm sure that many of you may not have experienced or seen this tonic-clonic seizure on your own, but I think this would be really, really helpful to everybody. So thank you, Madam Jeena and Srinitya, ma'am, for preparing and delivering that session.
Thank you, Diti.
Now, I would like to welcome our next speaker for the day, Madam Jessie Shaji Paul. She is a senior nursing officer in the neonatal ICU at AIMS, New Delhi. Madam did her master's from RAK College of Nursing in Child Health Nursing. She is also has done her BSc from AIMS, New Delhi. She holds a diploma in hospital management from NIHFW. I am really not sure. Did I share my screen? Oh, I'm so sorry. Okay, yeah, so Madam Jessie, and as I mentioned that she has a master's from RAK and her BSc from AIMS. Madam holds a diploma in hospital management from NIHFW, national faculty for on-top on essential newborn care for nurses conducted by the Division of Neonatology, Pediatric Department, AIMS, New Delhi. She is certified for QI training by IHI USA, served as Secretary IANN, alumni of the focus group exchange program of Rotary International, and the recipient of the Amazonian Best Research Nurse Award. So I welcome you, Madam Jessie, and her session for today will be neonatal sepsis. Over to you, Ma'am Jessie.
Yeah, good morning. Actually, Deepthi, I have a correction to say.
Okay.
Madam Achla Kumar is also there. She is supposed to take.
Yes.
Yeah, I think first session will be of her. So.
Okay, I think there is a change in the order. Let me introduce her as well, and then I guess you can start with your session.
No, first she will be talking about. First.
Yeah.
Yeah.
So. Okay, so we have we have the next speaker for the same topic, Mrs. Achula. She is the officiating nursing superintendent, Department of Nursing, Kalavati Saran Children's Hospital. She is an alumni of RAK College of Nursing and a PhD scholar with 26 years of professional experience. She is the national faculty for National Collaborative Center for Facility-Based Newborn Care. She established the CNE cell in KSCH in November 2016 and is working as a coordinator for CNE education cell there. Several awards to her credit and a Dux trained professional, trained in National TOT course for quality improvement coaches and Lakshya QI cycles, empanelment as external quality assessor of public health facilities under the NHM, and a National QI coach from NQOCN India provided on-site mentoring to SNCU across Jabalpur division and Niti Aayog aspirational district MP. So she is also going to deliberate the session on neonatal sepsis. Madam Achla, we will start with you. Please go ahead.
Thank you so much, Dikti ma'am. And first of all, I would like to thank the organizers for giving me this opportunity. I'm just sharing my screen.
Please.
Is my screen is visible, ma'am?
Yes, it is. Kindly put it on full screen and then you're good to go.
Okay.
Just a quick announcement before you start your session. I'm getting a lot of queries regarding the e-certificate and other things. So please, as I mentioned on the first day also, if you have attended the all 3 days of this webinar series, you will be getting your e-certificates on your registered email IDs, which you have shared. So that is about the certificates. About the Q&A, please start typing your questions in the Q&A tab, and any other query, please put it in and we will answer you. Please go ahead, Madam Achla.
Thank you. So the topic of today is management of neonatal sepsis. Sepsis is the most common cause of neonatal deaths worldwide, including India, contributing to almost one-third of all the neonatal deaths. WHO estimates that 1 million deaths per year are due to neonatal sepsis. If diagnosed early and treated with good supportive care and antibiotics, it is possible to save most cases of neonatal sepsis. Decreasing invasive interventions, promoting the breastfeeding, and maintaining proper hand hygiene, they are the best preventive strategies to reduce the occurrence of neonatal sepsis. The learning objectives are: after completion of this module, the participant should be able to identify the neonates with sepsis, enumerate the important etiological organisms, interpret the sepsis screen, and treat neonatal sepsis. So the definition is: neonatal sepsis is a clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. It encompasses various systemic infections of the newborn, such as septicemia, meningitis, pneumonia, arthritis, osteomyelitis, and urinary tract infections. So basically, the classification of neonatal sepsis, it is classified into two subtypes depending upon the time of onset of symptom. Like before 72 hours of life, it is called early onset sepsis, and if it is after 72 hours of life, it is late onset of sepsis. So in early onset of sepsis, where the sign and symptoms of sepsis appear within 72 hours of birth, the source of pathogens is the maternal genital tract or the delivery area. Respiratory distress due to congenital intrauterine pneumonia is the predominant manifestations of early onset of sepsis. In late onset of sepsis, where the signs and symptoms of sepsis appear after 72 hours of age, the pathogens are acquired from community or hospital, that is nosocomial, and late onset of sepsis commonly presents as septicemia, pneumonia, or meningitis. So regarding the etiology, most of the cases of neonatal sepsis, they are caused by the E. coli, Klebsiella, and Staphylococcus aureus. And the risk factors for the early onset of neonatal sepsis is caused by the organisms prevalent in the maternal genital tract or in the delivery area. The risk factors for early onset of sepsis, they include very low birth weight, that is less than 1500 grams, and prolonged rupture of membrane, that is more than 24 hours, foul smelling liquor, multiple or more than 3 per vaginum examinations in 24 hours, and intrapartum maternal fever, that is more than 37.8 degrees centigrade. In late onset of sepsis is caused by the organisms thriving in the external environment of the home or the hospital. The infection is often transmitted through the hands of the care providers. The associated factors of late onset of sepsis, they include very low birth weight, lack of breastfeeding, delayed enteral feeding, frequent handling, disruption of skin integrity with needle pricks, and use of intravenous fluids due to poor hygiene, poor maintenance of asepsis in neonatal units, including improper hand washing techniques, and superficial infections like pyoderma, umbilical sepsis, and previous or prolonged hospitalization. In clinical features, the clinical picture of the neonatal sepsis is highly variable. The sign and symptoms may be minimal, subtle, or non-specific, and common clinical features of neonatal sepsis, they are depicted as lethargy, refusal to suckle, poor cry, not arousable, comatose, abdominal distension, diarrhea, vomiting, hypothermia, and poor perfusion. And sometimes scleremia is there. Scleroderma neonatorum manifests as diffuse hardening of the subcutaneous tissue, resulting in a underlying structures becomes an unpinchable, starts over the face and legs and advances centripetally. If the skin over the chest involved, then breathing becomes more shallow and rapid. So there will be a poor weight gain. The most common manifestation is respiratory distress in early onset of sepsis and alteration in the established feeding behavior in late onset of sepsis. Hypothermia is a more common manifestation of sepsis than the fever, and pyelonephritis is common in males and preterms. Enlarged palpable kidneys are also there, and NEC also presents as distended abdomen, passage of blood or mucus per rectum, or bilious vomiting can be there. There will be a diminished or absent bowel sounds and peritonitis. Stool is positive for occult blood. Some of the common clinical features of neonatal sepsis, they are depicted as a shock, bleeding, renal failure. Renal failure can be suspected clinically by presence of edema, excessive weight gain, oliguria or anuria, cyanosis, tachypnea, chest retractions, grunt, apnea, gasping. It can be a fever, seizures, and the child will have a blank look, high-pitched cry, excessive crying, irritability, neck retractions, and bulging of fontanelle. So the clinical suspicion of etiologic agent like Staphylococcus, it usually after 72 hours of life, it presents as pyoderma, conjunctivitis, umbilical sepsis, abscess, osteomyelitis, and scalded skin syndrome. And listeria is peripartal maternal fever, and the baby limp at birth. AF is depressed or respiratory distress syndrome, apnea, skin rash, and hepatosplenomegaly. So the pseudomonas and Klebsiella, they can lead to grayish black gangrenous patches on the skin. As you can see, the patches at the back of the child, and it is umbilical infections, and these are the pyoderma and skin infections, and these are some of the very severe forms of sepsis. The child will look like this. And also it can result in meningitis. About 25 to 30% of septicemic neonates may have meningitis, which is often silent without signs of meningeal irritation, and symptoms suggestive of meningitis. They are excessive or high-pitched cry, fever, seizures, or bulging anterior fontanelle. So there are some diagnostic tests also. There are definitive or specific tests in which blood culture, CSF culture, urine culture, tracheal aspirate culture, polymerase chain reactions, and latex particle agglutination test. They are some of the definitive or specific tests for the diagnosis. And non-specific diagnostic tests like white blood cell count, C-reactive protein, CRP, micro ESR, and other acute phase reactants, these are there. So basically in the diagnosis, the direct method for blood culture, it is isolation of microorganism from the blood, CSF, urine, or pus is diagnostic. And in clinically suspected cases of sepsis, blood culture should be sent prior to starting antibiotics. And collection of sample for blood culture also, inoculation of 1 to 2 ml of blood is recommended for adequate and appropriate growth in a pediatric blood culture bottle. And the ideal ratio of blood to culture medium, it should be 1:10, and all the aseptic technique has to be maintained, and then only the sample has to be sent. So in indirect method also, there are a variety of tests which are helpful for screening of neonates with sepsis, like total leukocyte count, TLC, a total leukocyte count below 5,000 cubic millimeter, and an absolute neutrophil count, that is ANC, if it is more than 1800 per cubic millimeter, is an indicator of infection. Neutropenia is more predictive of neonatal sepsis than neutrophilia. Immature neutrophils, that is the band cells plus myelocytes plus metamyelocytes to total neutrophil ratio, that is ITR, if it is more than 0.20, means that immature neutrophils, they are over 20% of the total neutrophils.
This happens because bone marrow also pushes even the immature cells into the circulation to fight the infection. So the micro ESR may be elevated with sepsis, and a fall of more than 15 millimeter during first hour, it indicates the infection. And C-reactive protein, that is CRP, a value of more than 10 milligram per liter is taken as a positive. A negative CRP is reassuring. The CRP can also be positive in other conditions like perinatal asphyxia, shock, and meconium aspiration syndromes. So a negative sepsis screen helps to rule out sepsis. However, a positive screen may not be confirmatory, as the screen parameters may become positive due to many other clinical conditions like PIH, perinatal asphyxia, shock, meconium aspiration syndrome, etc. So the neonate with a positive sepsis screen may have an infection, or it could be positive due to other reasons. So a practical positive sepsis screen takes into account 2 or more positive tests out of the 5 given below. If out of 5 any 2 tests become positive, then it is said the sepsis is there. Like leukopenia, TLC, if it is more than 5,000 per cubic millimeter, and neutropenia, if it is more than 1800 per cubic millimeter, and immature neutrophils to total neutrophil IT ratio, if it is more than 0.2, and micro ESR more than 15 millimeter in first hour, and CRP positive more than 10 milligram per liter. So do not treat if WBC is more than 25 and glucose is it is less than 24 and glucose is more than 25, and the protein in preterms also WBC count, if it is more than 10 cubic millimeter, or if it is glucose, it is less than 24 milligram, and proteins, they are more than 170 milligram per liter, or in term babies WBC count more than 8 per cubic millimeter, and glucose, if it is less than 20 milligrams per liter, or proteins if it is more than 120 milligram per liter. So in C-reactive protein, CRP is synthesized by the liver following any inflammation, and a level of more than 1 milligram per DL is considered abnormal in a neonate, and a single value of negative CRP is not much of the significance. So in the non-specific diagnostic or septic screening test, like leukocyte count, TLC is around 8,000 to 20,000. It is normal in neonates. It is non-specific, and leukopenia, if it is less than 5,000, or absolute neutropenia less than 1,000, suggestive of sepsis, and band cell count more than 20%, and band cell count versus total neutrophil count, if it is more than 0.2, then it is suggestive of sepsis, and abnormal neutrophils, if it is present, then they are suggestive of sepsis. So in mature neutrophils, you can see some of the band cells are present. In micro ESR also, it is inexpensive and easy bedside screening test for neonatal sepsis. And if it is more than 15 milligram, it is suggestive of infection. Other acute phase reactants also, like prealbumin, fibronectin, and transferrin are negative reactants, and procalcitonin is produced in plasma of infected patients, physiologically elevated during first 3 days of life. Normal value is 0.5. It is indicator of late onset of sepsis. So the evaluation of extent of the disease is by the LP4 meningitis, urine examinations, X-ray chest, X-ray erect abdomen, stool for occult blood, and bone scanning can be done. And looking for the biochemical abnormalities like blood glucose, blood urea, serum creatinine, and total serum bilirubin, serum electrolytes, and ABG also. The management part, basically it is the early recognition and appropriate antibiotic therapy and optimal supportive measures, and these are to be taken by Jessie ma'am. So the next part is dealt with the Jessie Paul ma'am. Over to you, ma'am.
Thank you, Achla, for giving that vivid picture of what is neonatal sepsis, what is the risk factors, clinical manifestation, and diagnostics test. Let me share my screen first. I take this opportunity to thank the organizers for giving me the opportunity, and very good afternoon to all the participants and the faculty for this day. So as she was already told about the neonatal sepsis, let us come to the management part. So early recognition we have done.
Jessie ma'am, you haven't shared your screen. Please share your screen.
So is it visible now? Hello?
Yes, Jessie, it is visible.
Yeah, okay. So as Madam Achla has given the picture about the neonatal sepsis, let us come to the management part. So in the management, early recognition already we have done. Now coming to the what are the management steps? These are optimal supportive measures and appropriate antibiotic therapy. The supportive measures is one of the crucial in the management of sepsis. So main purpose of these supportive measures are to normalize the temperature, stabilize the cardiopulmonary status, correct hypoglycemia, and prevent bleeding. So we let us come to that one by one. So the supportive therapy, always remember that in any case, in an emergency situation or in NRP, we must be knowing that TABC is the sequence of managing the newborn. The same over here also in sepsis case also, we have to start with that. So providing warmth, maintaining the thermoneutral environment is very important. That is one of the main appropriate supportive therapy we are giving. So from the previous speakers and the day before also, we have heard about the hypothermia, all the stuff. So I'll not be elaborating on all these things. So monitoring the temperature and appropriate measures to make the thermoneutral environment is the nursing responsibility. So in coming to the airway and breathing, so if the baby's saturation is not maintaining, so we may need to administer oxygen. If apnea means cessation of breathing for more than 20 seconds, or cessation of breathing followed with bradycardia or desaturation is called as apnea. So for that, sometimes the baby may start breathing with the stimulation. In case it's not initiated breathing, they may need a bag and mask ventilation with oxygen is necessary, or in case if the apnea is repeatedly happening, the mechanical ventilation support may be needed for the baby. So the nursing responsibility lies for that respiratory monitoring, like how the baby is breathing, like chest indrawing, or the retractions are there, or a grunting is there, or so all these things we have to observe from time to time. And in case the baby need a respiratory support like CPAP, that is continuous positive airway pressure, or a mechanical ventilation, the care for that also has to be taken care. So the other is correction of hypoglycemia, and even sometimes we need to give boluses also. So for that, we need to establish a intravenous line. So during the procedure, like establishing the line, so we have the responsibility of maintaining the asepsis and fixation of the line and all that stuff. And in case the capillary refilling time is prolonged, so may need to give boluses, like preferably we give normal saline. That is 10 ml per kg is the dose we give 20 to 30 minutes. And in case still that capillary filling time is prolonged, we'll repeat the same 1 or 2 times more. So all these times we have to monitor the vitals. Then if the hemodynamically compromised babies will avoid enteral feeding. So for that, if the baby is not feeding, kept NPO, we need to administer maintenance fluid. So monitor the signs of shock and further deterioration if the baby is having. So all these things we have to monitor, and careful regulation of the fluid and electrolyte is also our nurse's responsibility. And if the perfusion is still persistently poor, even after giving the boluses and all, so we may consider the use of dopamine. So that Dr. Alpana Mai has already given you about how to prepare this dopamine and all. So our responsibility lies to monitor the perfusion, blood pressure, and careful monitoring on the infusion, the rate and the dose we are taking. All these things we have to carefully monitor. And in case the hypoglycemia is there, after monitoring the blood glucose, the stat dose like 2 ml per kg, that's the stat dose we give to correct the hypoglycemia. Again, we'll monitor and we'll start with the GIR since the baby is kept NPO because of the deteriorated condition. So in case observing for the signs of bleeding is our responsibility. And if taken the history and if the baby has not received at the time of birth, or if the baby has getting the antibiotics for more than 7 days, there is a need for giving vitamin K. That should be administered intramuscularly. And another this adjunctive therapy is the exchange transfusion in case the sclerema is there in the baby. So for that, we have to assist and prepare for the procedure. So the supportive therapy, so we have seen that temperature management, hypoglycemia correction, pulmonary and cardiopulmonary stabilization is happening, and preventing the bleeding by administering the vitamin K. So now coming to the antibiotic therapy, so there is no universal recommendation for all the settings because antibiotic therapy should cover the common causative organism. Like the studies have shown that E. coli, Staphylococcus aureus, Klebsiella pneumonia are the most common organisms found in the culture specimens. So the selection should depend on the covering of all this treating this organism, and also it should be based on the prevailing flora in the given unit and its antimicrobial sensitivity. But as a choice, it should be like combination from the penicillin group and one from the aminoglucosides. And it should be started if the presence of more than 3 risk factors are there, or if your positive septic screen has happened, or any strong clinical suspicion of sepsis, we'll start with the antibiotics. So once we have started, when to stop this antibiotic therapy, it's like we have started because of the risk factors and the clinical course not compatible with the sepsis and your screen turned out to be negative. So we'll stop after 3 days. So the other situation will be the culture is negative, screen is negative, but the clinical course, though the signs and symptoms the baby is showing is compatible to the sepsis, we'll treat for 7 days. And in case the screen is positive and the clinical course is compatible with sepsis, we'll go for 7 to 10 days for the treatment. And no meningitis, but culture is positive, we'll treat for 14 days. And in case meningitis is there, of course, we have to treat for 21 days, or that's called 3-week cycle. In meningitis also, cefotaxime is more preferred because of the penetration. It has good penetration to the cerebrospinal fluid. So it's a choice of drug, and one group of aminoglucoside is also given. So point to remember over here is there is not to be used, in case the baby's the meconium aspiration syndrome, or the baby is having mild respiratory distress, or birth asphyxia, or a asymptomatic neonate with presence of one or two risk factors, or jaundice or prematurity, unless the workup for sepsis is positive, we don't need to initiate antibiotic, because rational use of antibiotics has to be encouraged since the resistant floras are increasing. So that you have to remember. And continuing with the nursing management, apart from the supportive therapy, which I have highlighted, we have to observe for the complications like continuous monitoring. We can see how the baby's condition is improving or deteriorating. Or once the antibiotics has given, we have to know that we should know about the side effects of the antibiotics which we are giving, as well as because prolonged use of antibiotics, there could be infection like candida infection can happen. So we have to observe for that. And always remember, in all the treatment part, we have to encourage the family centered care. We have to involve the family, and we should provide care with empathy, and we should give emotional support and counseling to the parents. So involving them and giving the treatment course and what you're giving, so they'll have a confidence in us, and they will be more what do you say, they will be more comfortable with us also. So always remember, prevention is better than cure. So the best practices to prevent the neonatal infections are good antenatal care, and mother should make sure that mother has received a tetanus immunization, early diagnosis and prompt treatment of all the maternal infections, safe delivery practices like observing the WHO 6 cleans, and early and exclusive breastfeeding, no prelactal feeds, cord should be kept clean and dry, hand washing, that is the simplest and most effective method to control infection in the hospital as well as in the community. And in the hospital, we have to ensure that the clean and dry nursery environment, ensure the round clock water supply so that we can have the compliance to the hand hygiene, adequate ventilation, maintaining the environmental temperature of 26 to 28 degrees Celsius, avoid overcrowding, ensure strict asepsis during the procedures, and minimize the invasive interventions such as needle pricks and intravenous alimentation, and initiate the early enteral feed at the earliest. And in case we are in a primary setup or in the facility where we don't have much equipment to treat the baby, after initial stabilization, if the baby's condition is worsening or no improvement is there, so we must consider for referring to the higher center. So the worsening is defined as the development of the following features. It could be respiratory failure requiring mechanical ventilation, or unresponsive shock. We have treated with boluses, the inotropes, still it's not responding, and persistent or refractory convulsions are there. Disseminated intravascular coagulation diagnosed by bleeding or from the puncture site, or GI bleed or pulmonary hemorrhage, or baby requiring exchange transfusion, but facility is not available. So all these situations, we need to refer the cases. So now we will see some of the videos, which I hope the time is permitting. It's 4 videos are there on prevention of infection, which has been developed with the members of the IAN were also actively involved in the making of these videos. Thanks to the whole team who developed these videos. So let's watch of this on hand washing, preparation of medication, biomedical waste management.
Hand hygiene is one of the simplest and most powerful tool to prevent the horizontal spread of infections in
मैं अनेक पे कर देती हूँ कैसे
by 2 methods, hand washing and hand rubbing. In this video, we will learn both the techniques of hand hygiene. Let us discuss the infrastructure requirements For the hand hygiene, near the sink, we should have three posters. First, method of hand wash. Second, method of hand rub. And finally, third, 5 moments of hand hygiene. The poster of hand wash and hand rub provide the visual display of methods which act as a ready reckoner so that the steps of hand hygiene are not missed during the actual procedure. It is important to have either clock with seconds hand or digital clock with seconds display near the sink, which increases the compliance to the timing of hand hygiene. An ideal place of hand washing should have a deep sink so that the water doesn't splash back. An elbow operated tap to prevent the contamination of hands after hand hygiene. It is important to note that the bar soap should be avoided for hand hygiene as the base of bar soap is quickly colonized with resident flora and can lead to healthcare associated infections. Hence, a soap dispenser should be preferred over bar soap. The place should have sterile single use towels or sterile tissue papers to wipe the hands in the end. There are standard indications for hand hygiene, which are popularly known as 5 moments of hand hygiene. First, before touching the baby. Second, before doing any invasive procedure. Third, after handling the body secretions. Fourth, after touching the baby. And fifth, after touching the baby's surroundings. The selection of method of hand hygiene should be clearly understood. Either of the two methods of hand hygiene can be used. However, in two situations, hand hygiene should be performed only by hand washing. These are entry in the SNCU and after handling body secretions or when the hands are visibly soiled. Roll up sleeves of your shirt approximately 1 inch above elbow. Remove all ornaments and wristbands. Wet your hands and forearm by keeping below the free flowing water. Take adequate amount, that is approximately 5 to 7 ml of liquid soap in your palms. Gently rub all hand surfaces, including wrist, forearm, and elbows. Follow these steps in a given sequence. The first step is palm to palm rub. Second step is right palm over left dorsum with interlaced fingers and vice versa. Third step is palm to palm with finger interlaced. Fourth step is back of the fingers to opposing palm with fingers interlocked. Fifth step is rotational rubbing of left thumb clasped in the right palm and vice versa. And sixth step is rotational rubbing backward and forwards with clasped finger of right hand in the left palm and vice versa. After performing 6 steps, wash hands using running water starting from the hands. Keep hands little higher so that the water trickles down from the most clean area, that is hands, towards forearm. Dry the hands first and move gradually from the hands towards elbow. Avoid coming back from elbows to hands with the same paper, as the paper might have touched the non-sterile surface. In case we are using the other tap, use the paper in your hands to turn off the tap. Discard the papers in the bin appropriately. Hand washing should be performed for a total duration of 40 to 60 seconds. Now let us understand how to perform hand hygiene using hand rub. Hand hygiene using hand rub should be performed for 20 to 30 seconds. Push the nozzle of your hand rub dispenser 2 to 3 times to have an adequate amount, that is 5 to 7 ml of hand rub in your palms. The steps of hand rubs are exactly the same as we discussed in hand washing. At the end of 20 to 30 seconds, please wait till your hands are completely dry before touching the neonate. Your hands are now ready to touch the neonate. In the end, let us discuss some important points of hand hygiene. A combination of hand washing and hand rub should not be done. The healthcare professionals should avoid nail paints, long nails, and ornaments. The ornament should be taken off before undertaking hand washing. The hand should never be cleaned with the common hanging towel. Thank you.
In this video, we shall learn how to administer commonly used medications. Medications are administered to prevent disease, to treat disease, to aid in diagnosis, and to relieve symptoms. The articles required for injection preparation include gloves, syringes, 1 ml, 2 ml, 5 ml, and 10 ml, a pressure monitoring line, sterile water, normal saline, spirit swabs, and betadine swabs. Injection ampicillin, vitamin K, and phenobarbital are some of the common drugs that are used in the nursery. You will see the preparation of each one of them in detail. Injection ampicillin is available in 250 mg and 500 mg vials. It is indicated in neonatal sepsis, pneumonia, meningitis, and similar infections. Before preparing the injection, you should check for the written order of the physician. Here, the order is written as injection ampicillin 100 mg in 2 ml of normal saline to be given over 15 to 20 minutes in an 8-hourly schedule. There is a simple formula for calculation of the drug amount which has to be administered. That is, the desired strength of the drug divided by the actual strength of the drug multiplied by the quantity is equivalent to the amount of the drug which has to be given. Let us see this example. In this case, the desired strength is 100 milligrams, the actual strength of the drug is 500 milligrams, and the quantity is 5 ml. So, it's 100 divided by 500 multiplied by 5, that is equivalent to 1 ml. Hence, we have to administer 1 ml of the injection. We shall now see the procedure of the preparation of the injection. Wash your hands thoroughly. Wear gloves. Clean the top of the vial with spirit swab followed by betadine swab and then again by spirit swab. Add 5 ml of sterile water to the vial. The resultant concentration of the drug is 100 milligrams per ml. The amount that we have to administer is also 1 ml. But remember, you have to take the double dose of the drug to prime the pressure monitoring line and to give the right dose of the drug. Take 2 ml, that is 200 milligrams of the injection ampicillin in 4 ml of normal saline and prime the pressure monitoring line. The amount left in the syringe is 2 ml. Clean the port of the IV cannula with spirit swab, followed by betadine swab, and then again by spirit swab. Connect the prepared injection to the IV cannula port and infuse it over 15 to 20 minutes. Document the drug, document the dose, the route, and the time in the documentation chart. Remember, ampicillin is compatible with normal saline and ringer lactate. It is, however, incompatible with dextrose solution and sodium bicarbonate. Thank you.
Animals in research activities or in the production and testing of biologicals. Most recent update has been made by the Ministry of Environment, Forest and Climate Change and has been notified in March 2016. Biomedical waste are segregated into 4 appropriately color-coded containers. These colors are yellow, red, white and blue. Now let us understand where to place these containers. In a 10-bedded SNCU, one set of containers are recommended. This means that the sets would proportionately increase for every 10 beds. Place the containers in sequence, that is black, red, yellow, white and blue. Place the containers near the wash sink and make the biomedical waste containers accessible to the healthcare workers. These containers should be at least 10 feet away from a patient bed or warmer. Yellow and red coded containers can be either non-chlorinated plastic bags or hard containers. White coded containers must be puncture proof, leak proof and tamper proof containers. Blue coded containers must be cardboard boxes with blue colored marking and would not be a blue colored bin in total. One should ensure that the white and blue colored containers are not plastic bags. Now, let us learn which items should be discarded in which color coded container. Human anatomical waste, that is fetuses below viability period, soiled waste, that is blood or body fluid stained cotton and gauze piece, expired or discarded medicines, that is plastic antibiotic vials, plastic ampoules, etc., chemical liquid waste, that is aspirated body fluids, infected secretions, and disinfectants, discarded linen and mattresses and beddings with body or blood fluid, blood bags should be discarded in yellow colored container. In addition, all cytotoxic drugs along with their glass and plastic ampoules should be discarded in yellow bag. Waste generated from disposable items such as tubing, bottles, intravenous tubes and catheters, urine bags, syringes without needles, and vacuum and gloves should be discarded in red colored containers. Sharps including metals such as needles, syringes with fixed needles, needles from needle tip cutter, scalpels, blades or any other contaminated sharp object that may cause puncture and cuts should be discarded in white or translucent bins. Glassware that is broken or discarded including medicine vials and ampoules and metallic products should be discarded in blue bins. Remember, none of the container would be filled with 10% sodium hypochlorite as per the new recommendations. Apart from this, black colored containers would be used for general and non-infected waste like kitchen waste that arise from the hospital pantry and kitchen. Syringes should be mutilated or needles should be cut using a needle cutter before storage in white container. Now let us see briefly how this material are treated after segregation in the ICU. The waste material in yellow bags is incinerated or sent for deep burial. Chemical liquid waste shall be pre-treated. Linen and mattresses shall be disinfected with a non-chlorinated disinfectant before incineration. The waste material in red bags is sent for autoclaving or microwaving. The waste material in white bags are autoclaved or subjected to dry heat sterilization followed by shredding or mutilation, while the disinfection of the waste in cardboard box is done by soaking the washed gas waste after cleaning with detergent and sodium hypochlorite treatment or through autoclaving or microwaving and then sent for recycling. Thank you.
So there are two more videos are there. It will be shared. So the take home message from me is like prevention is always better than cure. The strive for the good practices like initiation and exclusive breastfeeding, compliance with the hand hygiene practice, maintaining the skin integrity and practice of good skin care, following asepsis during procedures and administration of medication, and good housekeeping to be observed. As we are the frontline workers, we should be more taking care of all these things. Practice family-centered care and quality improvement initiation has to be taken care. So always remember to prevent, more highlight to be given for the preventive aspects. Thank you.
Thank you, Madam Jessie. And I think that was again a very, very informative session. Now, I think we can quickly take a couple of questions, maybe one or two, which is, I think, important to be dealt. The other questions we have already answered. So the question is, it's not really actually directly related to any of the topics, but it's a general question. If a healthcare worker gets needle stick injury from infant, Do we need to get the blood from mother alone for tracing, screening of HIV, HCV, HBs, AG, etc., or need to collect from both mother and baby? Can you and any one of you answer the question, please, the panelists?
I think in the ANC period itself, we do that screening of the mother. So it depends. Right. Yeah. So I think the transmission will be, I don't know the status if the mothers is there, but it depends on the, it still we can notify this in the unit, wherever the protocol, like in the institution, we have to, the information has to be given to the chief medical officer, and they will assess and they will take the practice. I mean, the prophylaxis regimen, and if they recommend whether needed. It depends on the depth of needle stick injury, and that depends on that, it will be taken care.
Great. So notifying, or you can say incident reporting, is very important. Yeah. I think that needs to be taken care of. Another question is by Deepa Anand. She says, please let me know that if the anterior fontanelle is big in size, is there any problem in baby's speech and study? Anybody would like to answer that?
So the anterior fontanelle will be open in the first 18 months. So it's the closure, it depends on whether it's closed in the normal appropriate age. Otherwise, I think that should be concerned, and screening has to be done for that in case of that.
Okay.
I believe so, yeah.
Okay. Any additional answers to this, if anybody would like to add? So I think it is all about the normal closure of the anterior fontanelle that needs to be taken care. And if that is not there, I think it needs to be notified and taken care of. So basically, we have answered all the questions from our side. If there is any question pending, please don't worry. It will be sent to all the panelists and you will get your answers in mail. Also regarding the e-certificates and your the recording of the all 3-day session, as I mentioned in the beginning, if you have attended all 3 days of session, you will be getting your certificates in your registered mail IDs, along with the recording of the 3 days of the session, which will be very, very useful. But the PPTs or the content of the sessions may not be shared. That is something to be noted at your end. And I would like to thank all the speakers, including today's from day one, for being consistent, being timely, and bringing in such great information to all our participants. I think students have been the most useful ones here. And now I hand over to Madam Sareen for the parting words. Over to you, ma'am.
Thank you, Deepti, for so wonderfully chairing the session and holding it so well. And I think large number of candidates have been benefited out of these webinar series, which we held for 3 consecutive days. And I'm very grateful to Elsevier for giving us the platform for holding it and giving us all the IT support for conducting it so smoothly. I hope almost near about 1,000 candidates have been benefited out of it. And we have received feedback, and feedback form is available in the chat box. We would like to have more feedback from the candidates. We would also like to know from the candidates what are the other topics related to neonatology they would like to learn, so that we can again hold a webinar series of the similar kind. And if I just have a recap of all these 3 days activities during the webinar series, all the resource persons dealt with all pertinent topics of neonatology, and very nicely they have depicted the role of nurses. All the videos which were shown made it all the more clear to the group regarding the care of newborn with different disorders. And I hope that the students are carrying, or the delegates and the learners are carrying, key home messages from this webinar series, and they would like to implement it while they are providing care to our small sick newborn babies. And Indian Association of Neonatal Nurses is one of the association only for the neonatal upliftment, because we know unless and until the neonatal mortality rate is decreased, then only the sustainable development goal of 2030 can be achieved. So to march forward for SDG 2030, all of us have to join hands to provide safe care to our newborns right from the pregnancy, that is the continuum of the care, till they become children and they are able to raise their voice on their own and take care of themselves. Newborns, being that they are not able to convey their messages verbally, they are able to only give us non-verbal cues. So as nurses, we have to anticipate the care what they need, and we have to provide them the safe care without doing any harm to these newborn babies. So I'm looking forward to the feedback, and I would also like to inform the delegates here that we have our registration form available on our INN website. Indian Association of Neonatal Nurses has a website. The registration form is available and you can do your live membership. And once you do your live membership, we keep conducting the annual conferences and CNEs that will help you to uplift and upgrade your knowledge regarding the current trends in neonatal nursing care. So thank you all the resource persons for doing it so well, for being with us, for preparing and taking out time to compile the PowerPoints, to convey the important messages to the delegates, and to show them through the relevant videos and responding to their questions so well. And I'm very happy that we were able to respond to majority of the questions through the online platform, and some we have discussed during our deliberations, and at the end of the deliberation, I think that's a very good attempt. Still, we would like, if anything else is there, we would like to improve upon, we would like to have feedback. And thank you again, Elsevier, once again for collaborating with Indian Association of Neonatal Nurses Association and carrying out this webinar series. Thank you, everyone. Stay safe, stay happy.
Thank you.
Thank you so much, ma'am. Thank you, everybody. Have a great day.
Thank you so much. Bye-bye. Thank you,
Bye-bye.
ma'am. Thank you so much.
Thank you.
Thank you, ma'am. Thank you.
Thank you, everyone. Thank you, everyone.
Thank you, ma'am.
Thank you.